Yeah, good morning. Let me start by thanking you for inviting me to this extraordinary, interesting workshop, coming all the way from Norway. Learn a lot about cutting-edge program development and research in our field. And I'm going to talk about a parenting program that we have implemented in Norway. It's not the only program. We have several examples in Norway. We have the multisystemic therapy, we have functional family therapy, MTFC, we have Caroline Webster-Stratton's incredible years. But I think this program will serve as an illustration of some of my points today. And of course, we're going to change the map here from the United States to Norway. It's a bit different. And of course, the proportions are a bit smaller than you're used to. But I think it's very interesting to see, can you move any of these programs developed in the United States across the Atlantic Ocean without dropping anything into the water? And I want to say a few words about how we worked in order to go to scale with the PMTO, the scaling up process. And then, of course, equally interesting, the sustainability of program implementation and also the treatment integrity. And there are two aspects of that topic. One is fidelity across time and fidelity across therapists. And then last but not least, say a little bit about program adaptations. What we learned from the parenting programs, we heard a lot about at this workshop, and how we try to adapt and modify those to suit the Norwegian context. Norway is, by US standards, a small country. We have about 5 million people, about 1 million children and youth under the age of 18. But it's a long-stretched country with many rural settings and long travel distances, which is a challenge in many respects. Norway and the Scandinavian countries are well known for being, or calling themselves, a welfare state. And some of the important principles are inclusion, equity, and decentralization, which is also important for how we have implemented programs in Norway. Important part of this is that we have free public health services. So they're funded by the state, by the municipalities, and we have free education in Norway. So that's an important background, I think. And we have also been highly receptive to empirically supported intervention or evidence-based practice. I think we have maybe only one contribution which has gone the other way, and that is Donald Weyu's anti-bullying program, which traveled from Scandinavia to the US. Otherwise, it's the other way around. And the start of our project has been a long-term governmental funding of a national implementation and research on evidence-based intervention. Although we have a high level of autonomy at the practitioner level and in local communities, we have this intention, the goal of the government to implement some of these programs across Norway. In 1999, this process started, as you can see here. And what the government wanted was to increase the capacity and the competence in the treatment of antisocial behavior. They want to decrease the amount of incarcerations of children and youth and have fewer placement out of home. So they were very interested in family programs, as we heard about this workshop. So what was defined, and I was a part of that team, we defined what we called a nationwide implementation strategy, that it should be, in a principle, equity, available to all children and families across Norway. And I think an important part was the establishment of my center, the Center for Child Behavioral Development, and our aim was to develop, implement, and evaluate evidence-based intervention. So we tried to build up a strong implementation infrastructure with national implementation teams, and we tried to combine a top-down, a bottom-up approach. That is to say that we at the center tried to select the programs that we thought was the right ones to put our stakes on, and in a way define the structure of the implementation, but then we had to recruit the practitioners. They had to volunteer to participate in the training and the practice. So in a way we were relied very much on their motivation to participate in this project. So we tried this hybrid model of implementation. And the trainees were then selected through the regular child and adolescent services across Norway. So in a way, you couldn't just apply for the training. We went out to the services and said, will you please pick up some people who volunteer to participate in the training? And then you have to promise that they will be able to work with this program when they're trained. So then we had these procedures for the sustained recruitment, training and supervision, and evaluation of practitioners, and also the implementation, maintenance, and quality assurance of empirically supported programs. Tell a little bit more about that. See? So in a way, this was our structure. We have 5 health regions in Norway. Okay, some more people coming up. And there we have a small group of purveyors, implementers, who worked around the country, but then most of our people are out around Norway. In the different health regions, we have teams organized very tightly, and a good training program we offered these groups of people all over Norway. So one of the challenges was to scale up, because the first thing we did was to do a full-scale replication of the PMTO in Norway. Because people said, PMTO may work in the United States, it won't work in Norway. So in order to convince them, we did an effectiveness study, not an efficacy, but effectiveness study. So we evaluated PMTO out in the regular services, but it was a small-scale study. And afterwards, with generous funding from NIDA in the United States, a large-scale implementation study was conducted by Marian Forgage and her colleagues. This was a non-randomized study in order to see what happens when we go to scale with this program. And we trained 3 generations of therapists, publication by Forgage and DeGarmo, and also we study these therapists over time to look at the changes or the stability of fidelity. And we found that despite large heterogeneity of, among the service providers and in the target population, no drop in treatment fidelity or attenuation of program effects were detected. So in a way, we managed to keep the pressure up, or the quality of the implementation and the quality or the treatment integrity. So there were 3 generations of PMTO therapists who contributed to this study. And I don't expect you to read those numbers, but we are having this in a publication showing that the behavioral change for the children enrolled in the treatment was equal to that in the effectiveness study. So with no differences. And involved here were 3 generations of therapists, almost 200, and about 300 families also included. And of course, we were interested to look at fidelity drift, the possibility of fidelity drift, and this was a study of Marian Forgage and Dave DeGarmo. And looking at this process, they found this model that the fidelity predicted outcomes across the 3 generations of therapists. And so we follow this implementation study. The first 3 generations here were involved in the NIDA study, and then we followed up and monitored fidelity across 3 more generations. And this, we used the fidelity of implementation rating system, in which the therapist's competent application of PMTO is monitored. Ratings are based on direct observation of the therapist's work with families, and the scores are in the range of 1 to 9, and video recordings are used to score the FIMP, the fidelity of implementation ratings. And as you will see from the numbers, they are keeping themselves at a very high level, very satisfactory. So we see that even though successive generations of therapists are trained, the level of FIMP is maintained. Another question I think is relevant in Norway as well as in the United States is the question about drift, program drift or fidelity drift for therapists when they work over time, that they have some private ideas and drift away from the program. Another discussion we have in Norway is the discussion between what we call common factors and program factors. And some of our colleagues in Norway maintain that all you need is therapeutic alliance with a family. If you establish a good alliance, the results will come. You don't need a program, actually. So we put this to the test, and this was a longitudinal study of fidelity across therapists over 3 time points, and at the same time, we asked the parents to rate the therapeutic alliance. And as you may see from this picture, I can tell you that the fidelity to PMTO predicted outcomes. Therapeutic alliance did not. So it seems that when it comes to parenting programs, it is, and particularly for antisocial behavior, it is important to have high treatment integrity or fidelity, and the therapeutic alliance may not be enough in order to secure the positive outcomes. I would like to add that the alliance level was pretty high in this, but fidelity predicted clinical outcomes over and above therapeutic alliance. So that really sparked the discussion in Norway around the relationship between therapeutic alliance as a common factor and fidelity as a more program-oriented factor. We also used Dean Fixen's and colleagues' system for evaluating our interventions. So 10 years after we started the implementation of PMTO in Norway, we did an interview with about 100 randomly selected PMTO therapists in order to look at the 2 kinds of drivers we have, competency drivers and organizational drivers. And what this figure shows is that we have been highly successful, rather successful by implementing the competency drivers. So we're doing good training, good supervision, evaluation of practice. We also do a good job at systems intervention, working with the surrounding systems of the therapeutic, but we have not been that successful in blending the PMTO within the usual services, because most other services in Norway are not evidence-based. So it's quite a difference there in the kind of procedures that are used. So with looking at these outcomes, we said, okay, we have to work more with the local organizations in order to blend in the evidence-based practice with the usual services they offer. The number of families by Norwegian standards have increased from 200 in 2002 and is now around 3,000 parents or families served each year in Norway with a PMTO. So I think that's a very nice development, and of course the politicians are very happy about this development. And then we had a look at program adaptations. As Mary Jane has written in one article, PMTO may overserve some families. It's 20 to 50 sessions. Some may manage with less. So we looked at maybe make this simpler, maybe lower the threshold for contacting services, and can we decentralize this treatment? And so we made a program which is built on the same principles as the PMTO, but in a way divided into brief parenting, social skills training for children, parent groups. PMTO is usually delivered to individual families, and also a module for school consultation. And we see that this program is well suited for the rapid identification and intervention, and we have implemented this across a variety of primary care settings like public child health clinics, schools, kindergartens, and this adaptation has a low threshold for intake. It has fewer sessions, lower intensity, and shorter duration than full-scale PMTO, to see other families who can manage with less. And based on the PMTO principles, we trained key personnel in the municipal child services. We developed training and intervention manuals, and we did a description of the core intervention components. And by 2014, by now, we have more than 1,200 practitioners in 81 out of 430 municipalities in Norway. And this is what it looks like. There are several modules. We have a PMTO full scale as a sort of backup, and then we have a brief parent training in which we train local practitioners 9 days over 6 months, followed by 6 months supervision of practitioner in local services. And these are delivered to parents. And if you compare it to the PMTO full scale, which is a 20 days training over 18 months, and it might have 20 to 50 sessions. So in a way, we're making it more brief. And of course, in line with our principles, we made a randomized controlled trial to see if this module was working. And then we have a social skills training module for children. We have a group intervention, and particular for ethnic minority mothers. I'll say a few words about them afterwards. Then we have the PMTO group intervention, and then we have a consultation model to practitioners in schools and childcare. And we deliver the training for the local practitioners. We recruit them from the municipalities, and then they start working in their own municipalities. And we tested all these modules with randomized controlled trials to see if they are working, and they are. So by now, it's spread all over Norway. It's a strange country, 5 million people, and we have 430 municipalities. So some of them are quite small. But there's been a tremendous interest in participating in this program. It's our capacity that's limiting the amount of implementation, actually. So see, this is growing. Just a few words about the brief parent training program, which is a short version of parent management training. It's 3 to 5 sessions delivered by regular staff in municipality child and family services. We had a clinical trial, positive outcomes also in the follow-up study after 6 months. But we also saw that there was no generalization effects to schools or kindergartens, which we saw for the PMTO that did generalize from home to school. But this brief intervention did not. So it indicates that in order to have this to work, we have also had to contact or work with the teachers in the schools or kindergartens. Another challenge was ethnic minority groups, because they don't volunteer, they don't come. We say, we have the medicine, but the patient don't come. And that is a challenge we try to overcome by hiring what we call link workers to contact Somali and Pakistani mothers, who are the dominant immigrants group in Norway. And they came, they participated, they ate our food, we had different activities, and we had a randomized control trial, waitlist control. We had 18 weeks of training in groups, and we had very optimistic or rather positive results. But once again, the outcomes did not generalize to kindergartens or school, but as you may have experienced in your own projects, mothers and teachers co-identified very few children with problems. So there is a challenge for us, but as a training program for the mothers, it worked out very well. Last, gaps in the science. Research answers some questions and raises some new ones. And we can see that although we are serving quite a number of families, there are quite a number of families who are not served. So in Norway, we have an estimate that about 3.5% of children under the age of 18 have conduct disorder or oppositional defiant disorder. And today, only 0.4% are receiving treatment. So still, there is a gap there, and we have a job to do to implement it more across the country. And then, of course, we're looking into family who drop out from treatment. We're particularly concerned with emotional dysregulation, children with callous and emotional traits, children with difficult temperament, and trying to work out modules in order to serve them better. And of course, we're working actively to work with program drift and the challenge of practitioner turnover. And of course, the new idea about integrating common elements that Charpita Daladen and John Weiss has been working on. So we're now planning to to try out the match intervention, modularized intervention in order to fix this challenge. And then, of course, the generalization question. Thank you.